Okay,
sir.
Dr. Goel, you're there, correct?
Yes, yes.
Oh, good. Here you are. Great, great. We segue right to the next show. Great.
Yeah.
Good morning. Good morning.
Good morning, John.
Okay, you're welcome to start.
Okay, so I'm actually John. There is some, the title is not philosophical. I'm going to talk on another subject. Maybe philosophy is my favorite subject. I'll talk on some other day.
Okay.
So today I'm going to talk on a very important subject for neurosurgeons. And that subject is on meningiomas. Are you with me, John?
Yes, yes.
I'm going to take the participants to the world of meningiomas. As you all know, meningiomas are very important for all of us, and they actually form a part of our life. We spend so much time with meningiomas. Once you start, you have to finish. They are difficult operations. More importantly, they are different. Every meningioma is different. Every meningioma has a different problem, and the manner to resect the meningioma is different for each patient. If you enter into the neurosurgery corridors, you hear the word meningioma, glioma. All our lives, we have been thinking, we have been talking, and we have been discussing about meningiomas. And we learn how to operate into the world of neurosurgery by operating on simpler meningiomas and then going on to complex meningiomas. How to remove the tumor, how to control bleeding, how to resect, how much to resect, whether the dura has to be resected, whether the bone has to be resected. Of course, the safety comes first. So there are so many issues when we are going to operate on meningiomas. So I am going to take you to my own personal world of meningiomas over the last several years. And in the last several years, I have seen that the advances in the treatment of meningiomas has basically been of gadgets. Initially, we were not using microscope, then we started using microscope, we use endoscope, we use bipolar, we use advanced bipolar, we use navigation. But basically, these advances have not been conceptual. Concept has remained the same. Operate, resect. And of course, adjuvant treatment has improved. The investigations have improved. And our own surgical techniques and technology has improved. So I'm going to show you several images today. Rather than the technique, I'm going to discuss about the philosophy of meningiomas, about the variations in meningiomas. So you see this beautiful sentence, no two meningiomas like two fingerprints have ever been alike. These are the fingerprints of various people, and you must know that all the 7 billion people on this planet have a different fingerprint. Similarly, I have to say that all the meningiomas on the planet that we see are different. And this difference in these meningiomas, I'm going to be discussing with you. The other thing that is different in every dog is the nose print. Do you know how the dogs are identified by the print of their nose? And every dog and every animal on the planet has a different nose print and a different shape of the nose. The other thing that is different in all of us, the entire human population on the planet, is the difference in the voice. There are no two human beings with the same voice. So how this difference happens is the hugeness or the mightiness of our nature. Similarly, the ear lobule, the make of the ear lobule is different in all human beings. There are no two ear lobules similar in shape or size or architecture. And for us neurosurgeons, we have to realize one very basic concept, that no two cerebral hemispheres are similar. The sulci and gyri and the pattern of sulci and gyri, the width of the gyri, the presence of these arteries and all. So these sulci and gyri are completely different in all human beings. To the extent they can form, if you take the print of your brain, it can be a very beautiful identity card of yours. So if you want to make a real identity card of yours, you must make the print of your brain. As regards my subject is concerned, is about meningiomas. So one basic thing I want to discuss is that all meningiomas are different. The second that I want to make for you is, once a meningioma, always a meningioma. Means if there is a patient gets a meningioma, he can never actually be free of a meningioma. It may be that you remove the tumor. You can remove the tumor, but not the capacity of the body to make a tumor. And once a meningioma has been made by the body, the meningioma is always possible to recur. So your extent of resection, you say, I have removed the meningioma, now the person is cured, is not such a great sentence. Similarly, once an acoustic tumor, always an acoustic tumor. So sometimes a situation might come to you that you have removed the entire tumor, a small amount of tumor is remaining on the facial nerve. Don't ever think that removal of that part of the tumor which will damage the facial nerve will cure the person. Once acoustic, always an acoustic. More important is, when we are going to operate on acoustic, what matters is the result of surgery, the outcome of surgery. Radicalness, of course, is important. But the result of surgery, the saving of facial nerve, the saving of hearing nerve. So in neurosurgery, what is important is tomorrow. What is important is not what will happen after 10 years or 15 years. Of course, that is important, but that is not the primary aim of the surgeon. Primary aim of the surgeon is to resect the tumor radically and save the function of the tumor, of the person. Similar concept is for malignant spinal tumor. This beautiful article we had written long time ago. For malignant spinal tumor, of course, we want to remove it completely and radically and show images before operation and after operation. But we should never be sure that your radicalness and the technical mastery that you will be able to show in your operation is all that the patient requires. So you see this, if you can read this beautiful sentence, when you see something that is technically sweet, you go ahead and do it. and you argue about what to do about it only when you have got your technical success. That is what it was with atom bomb. So he made atom bomb. He designed a beautiful technological gem called atom bomb. And when the atom bomb was blasted and the results that he saw, he made this beautiful sentence that lure of technically sweet and lure of technologically sweet should not be the guiding force. Another beautiful sentence here is, without health, life is not life. It is only a state of languor and suffering, an image of death. So our job as a neurosurgeon is to give a life which is relieved of the presenting symptoms, and we should try to do as radical as possible our surgery. So radicalness, if it is not in your temperament, if you want to do a partial resection, if you want to do a biopsy, that is not neurosurgery. Radicalness should be in your character. Radicalness should be the aim of the operation. But radicalness does not mean that there can be a disaster. Of course, that disasters happen in our life. Disasters happen all the time, but we have to learn from those disasters. So all meningiomas are different. If you ask me, the key word in meningioma is the variability. The clinical presentation is different. The radiological features are different. Surgical difficulties in each patient is different. Not only the surgical difficulties, the pathological variations. If you see the if you examine each specimen, the cellular architecture, the multiplication rate, the kind of staining that you will see, all meningiomas have a different pathological variation. No two meningiomas are similar. More important for us neurosurgeon is that outcome of all meningiomas is completely not in our control. In our control is only radicalness of resection, but outcome is variable in all tumors and all meningiomas. So I'm going to show you several images. First, I'm going to show you some supracellular meningiomas. You see, this is a small supracellular meningioma. This is a little bigger in size. This is more bigger in size. This has a huge, quite a large basal attachment. This has big anostosis and quite a large anteroposterior extension going along the optic nerves on the other side. So it is different from what you had seen in the earlier image. So this is another meningioma. You see some raggedness has come in picture. The extension is quite different. This is another tumor. You see there is an anastosis here, and this is the tumor. This is bigger anastosis, big anastosis. You see this tumor anastosis. This supracellular meningioma is looking like a pituitary tumor, but it is a meningioma, so it is relationship with the pituitary gland is variable. It is attached to the tuberculum celli, and it is away from the pituitary gland, away from the optic nerve. It is closer to the optic nerve and closer to the pituitary gland. Such meningiomas can be accessed by nose. I am not saying should be accessed. I am saying can be accessed. In my dictionary, there is no nasal approach for these kind of meningiomas. All these meningiomas have to be and has to be removed from transcranial subfrontal route. Endoscopic removal, in my view, is not such a great operation, maybe quite don't like to use any unnecessary words here, but it is not a good option. This tumor is a little bit eccentric. You see, it is not in the midline, it is going off the midline. This is going more off the midline, and it is almost like an anterior clinoidal meningioma. This suprasellar meningioma has a bony shell, calcification around the meningioma. And when there is a calcific part in a meningioma, it is different. The surgical issues are different. The complexity, the kind of resection that you will do and the difficulties that you will encounter will be different in case of solid, firm, and calcific tumor. So if you ask me which is the main factor that will determine the extent of difficulties during suprasellar meningioma resection, I will say the firmness in the character of a meningioma and presence of calcification determine the firmness of the tumor. This tumor is encasing the anterior cerebral artery complex, and this is another difficulty during suprasellar meningioma surgery. When you operate on these tumors, if you ask me, one very important and the most crucial aspect of surgery on these tumors is to preserve the anterior cerebral artery complex. If you take one perforator from the anterior cerebral artery or from the anterior communicating artery, there is a big possibility that you can damage the person, and you can damage the person in a very bad manner. So this surgery, the outcome of this surgery, just a minute, please. The outcome of surgery in these cases will be determined by how you preserve the perforators of this anterior cerebral artery. So when the artery is encased, you have to, whether it is encased or not, the surgery involves exposure of the artery early in the operation and separating the artery and the branches early in the operation. That forms the basis of tuberculum celli or suprasellar meningioma surgery. Any kind of nasal approach will not give you the access to these arteries early in the operation. And there is no way you can damage these vessels. Suprasellar meningiomas are difficult operations. You have to, and there is no way you can sacrifice one single perforator. So here there is anterior cerebral artery is encased by the tumor, internal carotid artery is encased by this tumor. So when you are going to plan operation, you have to see what is encased and what is not encased. More often, when the artery is encased by the tumor, they are soft tumors. When the artery is displaced by the tumor, it is a firm tumor. When the artery is encased by the tumor, more often they are firm tumor and less aggressive tumor. No, when they are encasing the artery, they are softer tumor and more vascular tumor and relatively more aggressive tumors. So tumors which displace the arteries are better for the patient. They may be little firm, and when they are firm, that firmness makes the operation little bit tricky. So there are two things. One is the firmness of a meningioma. Second is the vascularity of the meningioma. Firmness is bigger issue than the vascularity of the tumor for me. This is another tumor. There are speckled calcification within the tumor. You see here, there are speckled calcification within the tumor, and the arteries are displaced by the tumor. This is another tumor which is almost completely ossified meningioma. Now, many of these meningioma are very slow growing meningioma. And when they grow slow, they are benign, more benign tumors, more benign in their character. In some of these cases, the symptoms are long-standing and their person may not even need surgery. So when you see the tumor, you can determine the nature of the tumor, the character of the tumor, and also will determine how you are going to operate on this tumor and what will be the surgical difficulties that you will encounter. I will say if you get such a tumor with marginal symptoms or no symptoms, you might even consider a non-operative kind of treatment because these tumors are very slow-growing tumors. This is another tumor with bigger bone reaction and wider extension and speckled calcification within the tumor. Now, this tumor is different supracellular tumor with extensive surrounding edema. So what I'm trying to show you is that all tumors are different. All tumors are different in their radiology, and all tumors are different in their behavior and in their response to the brain. So long time ago, in the year 2001 or 2002, I had written this article with experience of 70 cases of tuberculum-cellular meningiomas. And now in the further 18 or 19 years, we have reached about 300 cases of tuberculum-cellular meningiomas. And this tuberculum-cellular meningioma forms a very important part of my life. I enjoy doing these tumors. And there is no question that these tumors are very important for all neurosurgeons. So till May 2001, this was my series. So according to the character of the tumor, we had graded the supracellular meningiomas to assess the extent of surgical difficulty, to assess the extent of resectability that will be possible, and to prognosticate the visual outcome in that paper in 2001. So we identified some clinical parameters and some radiological parameters. You should also know all cases, all patients present with different symptoms and signs. There are huge variation in the clinical presentation. So on the basis of clinical parameters and radiological parameters, we divided meningiomas into different grading systems. So age of presentation was different, and according to the age, we gave some points. So in that series, this was the grading number of patients. The other thing is the duration of visual symptoms. If you ask me, in supracellular meningiomas, the duration of visual symptoms is very important feature that will determine the extent of surgical difficulties. The longer the duration of symptom, if the symptoms are for 10 years, makes the surgery difficult. If the symptoms are only for 3 months or 2 months, it makes the conduct of surgery different. So longer the duration of visual symptoms, worse, firmer the tumor, benigner the tumor, less vascular the tumor, there may be calcification in this tumor, but more intense relationship with adjoining optic nerve and internal carotid artery, and the anterior cerebral artery complex, which is the most critical part of this operation. The other thing is extent of visual deficit. If there is a partial deficit or there is a severe deficit, partial means vision, finger counting at the region of 6 feet. Severe deficit is visual counting, only finger counting less than 3 feet. So this is the kind of deficit that we had written and given points. More severe the visual deficit, more aggressive the visual deficit, more difficult is the surgical resection of the tumor. So this is another feature that if you're going to do supracellular meningiomas, you must remember that the extent of visual deficit and the duration of visual deficits are very important features that will determine. If a patient with supracellular meningioma comes with hemispheric deficit, which is extremely rare, the extent of surgical difficulties will be different. If the person has come with altered sensorium, which is extremely rare, altered behavior, which is extremely rare, if the person has come with seizures, it means that this tumor is involving the brain. and disturbing the chemistry of the brain. If the person has come with endocrine disturbance, which is extremely rare or never seen. So if you see these features, I will say you never see this hemispheric deficit, you never see altered sensorium, you never see altered behavior, you see frequently seizures, and you never see endocrine disturbances in suprasellar meningiomas. If the person has diabetes, hypertension, and pregnancy, this makes the operation a little bit. So I had given points and graded these tumors: calcification, paranasal sinuses. When the tumor involves the paranasal sinus, it is a different tumor. When it involves the optic canal, it is a different. Hyperostosis, multiplicity of the tumor, encasement of the anterior cerebral artery, encasement of the internal carotid artery, encasement of ICA on both sides. If you ask me, anterior cerebral artery encasement is more dangerous an issue. The resection or dissection of the anterior cerebral artery is more difficult in suprasellar meningiomas than dissection of the ICA from the suprasellar meningiomas. Hydrocephalus is an extremely rare phenomena in suprasellar meningiomas, but when there is mild, moderate, or severe, it grades the tumor differently. Cerebral edema is also very unusually or rarely present in suprasellar meningioma, and when it is present, you give points to this tumor. So according to tumor difficulties during operation, the extent and feasibility of resection of the tumor, and more importantly, the ultimate outcome.
Okay, I think everybody knows what's going on. We just wait. Hopefully we'll get lucky. Usually we do. So just hang in there. As you know, it's because of Wi-Fi problems or Wi-Fi overload, whatever. And usually he'll get bumped off and come back. And we've been lucky the last couple of days. Yesterday's transmission was totally free of that problem, but the day before was problematic. Hopefully he'll be back. Think of this as the coffee break during the conference. Although coffee break without the coffee, without the tea. Are you there, Dr. Shah? Oh, I think he's okay. Okay, I think he's back. Nope, I was wrong. Not here. Good day, Sunil. I'm just picking people on the panel that I know. Stuart, are you there? We're just waiting for Dr. Goel to reconnect with his Wi-Fi connection. Okay, he's back. Here he is. Okay, good. Okay, we will resume, hopefully.
John,
Yeah, hi, we're here.
I'm working on it. Just give me a few minutes.
Okay.
I'm sorry for this, but unfortunately I cannot help, as I mentioned to you, my dear John.
Okay, we always make it through.
Yeah, it will come. Just to give me a few minutes.
Okay.
John,
Yes.
if they have any questions till now, I may be able to answer in the meantime.
Okay. Okay. Any questions or comments from the panelists, please?
Yes, can I ask, please?
Yes, you can.
Yes, dear Atul, what your explanation that the meningioma itself has multiple problems with pathology, with the imaging? What make it totally different from other tumors?
That is a very difficult question to answer, but they are different, as you know. All meningiomas have different features and different characters and different presenting features and radiological features, and that is what makes our life interesting. Imagine now if all the meningiomas were similar and all the meningiomas had similar kind of bleeding situation, then our life in neurosurgery would not be so interesting. You agree with me?
Yeah, yes, actually, I agree with, but I'm looking for the factors. Is it the relation with the vessels? Is it the relation with the dura mater, or what makes is different in behavior also?
I am not sure if I will be able to answer why they are different, but God has made them different. That is what is the issue. Just a minute, I think I'm...
Does he accept insurance?
Yes, you make it very hard for me.
Just a minute, I think I am about to get it.
Okay.
Yeah, yes, we are waiting.
Any other question in the meantime, John?
Okay, panelists, step up. Any comments, questions?
Hello.
Go ahead.
Yes.
Oh, go ahead, Victor.
A comment. I enjoy a lot your lecture, Dr. Atul Goel. The beginning of the lecture was really nice about the philosophical point of view of meningiomas are not the same. But you know, when we operate a meningio, specifically a petroclival meningioma or the anterior floor of the skull base. So how do you consider the success of surgical resection. If you remove most of the tumor, but you cannot resect all the tumor, is a success.
Okay, Atul.
So it's a success.
Let's see. Atul dropped off one of his sites. I'm not sure if he's on the other. He may not be with us for a second, Victor. Hold on.
Yeah.
Let's see. He usually comes back pretty quick. Okay, there he is. Okay. Are you there, Dr. Goel? Oh, he's calling him to get back in. I didn't even see him. Okay. He's coming here now, Victor. Okay. Okay. Welcome back, Dr. Goel. Are you there, Dr. Goel? Okay, he's here. His two accounts are here.
We cannot hear any voice. He's explaining.
No, he knows what's going on. He knows how to get back in and stuff. But his audio.
He's muted. Can you unmute him, John?
No, he's not muted. He's got it. He's not muted.
Yeah, I think he's explaining, but I can't hear anything.
Okay, there we go. There we go. Okay.
Excessive coagulation within the confines of the tumor may be a negative kind of an operation. This tumor is a little bit posterior, but one thing I can tell you, the pituitary stalk is completely free from the tumor, and there is a well-defined arachnoid plane in almost 99% of these cases. So pituitary stalk can be saved rather easily if you do not coagulate too much in the vicinity of the pituitary stalk. Some of these tumors can be rather easy. I should not use the word easy in neurosurgery because it is a wrong word to be used. But some of these tumors, you learn the art of breaking the tumor, This artery will be dissected rather easily. Optic nerve will be in relationship with this tumor. You have to dissect the optic nerve. The tumor may enter into the optic canal in more than 25% of patients. Then you have to drill the roof of the optic canal and remove the tumor extending into the optic canal. It may be extending on both sides of the optic canal. This is a calcified tumor with multiple calcification with this tumor, makes the operation a little bit more tricky, makes the relationship of the arteries to the tumor a little bit more intense, and dissection a little bit more difficult. So you have to see the nature of the tumor. You should know beforehand the extent of difficulties that you will encounter. Tumor with calcification makes the tumor resection a little bit more difficult. Despite the firmness of this tumor, the pituitary stalk will be intact and safe, and clear plane of dissection between the tumor in more than 99%. 99 I'm using because in my 300 cases, not exactly 300, maybe a little bit here and there, there have been some cases where pituitary stalk has been involved by the tumor. This is another tumor extending on one side, but you see here in this tumor, which is very rare, necrosis within the tumor and cystic components within the tumor in a meningioma are extremely rare situation. In this kind of tumor, you will know that this tumor is softer tumor, maybe more vascular tumor, but resection may be easier. This is another tumor and resection. And as we go further, I will come to videos on these cases. Of course, videos more important to show videos rather than showing the images, as we all neurosurgeons know. But this tumor, the dissection of the internal carotid artery and the branch of the internal carotid artery is easier than identification of the anterior cerebral artery is the more important issue. This is another tumor with calcification and this resection. Whilst resection and dissection is going to be a goal of the surgery. Other issue that I wanted to touch is the anastosis. How much of the bone should be removed? How much of the dura should be removed? How much of the dura is involved by the tumor? If you see this tumor, you see there is a enhancing tail of the tumor. This enhancement of the tumor is, you have to coagulate this part of the tumor quite aggressively. I do not remove the basal attachment bone. Sometimes the anastosis can be quite deep inside. I remove the anastosis, which is disturbing my resection. You see, when you come from here, the dissection of this part of the tumor may become a little bit tricky and difficult. In that situation, I will remove the anastosis, but in general, I do not like to resect the bone of the base of the skull to make the resection more complete. You see, this is the base of the skull and attachment. I will remove this attachment only till the extent that it disturbs my surgical exposure. This is tumor involved. Many of these tumors are very straightforward tumors. Victor, you know it. Many of these tumors are quite straightforward and simple surgery. I should again not use the word simple or easy, because this depends on the variations and variability of the tumor. Every tumor is different. Every tumor has different characters and different kind of problems. Some tumor is left behind here because maybe the anterior cerebral artery is stuck. So more important is, of course, you have to dissect. Of course, you have to aim for radical resection, but you can never try to compromise on any single perforator. And if you have to compromise on anterior cerebral artery feeder perforator, not feeder, I must not never use the word feeder. The feeders are from the base of the skull. There is no feeding vessel from the anterior cerebral artery or from the internal carotid artery. All the feeders are from the basal dura. If you coagulate inside the tumor, it is not such a great idea. If you coagulate outside the tumor, you have created a disaster. All the coagulation in these kind of tumors have to be on the base of the tumor attachment and not on the dome of the tumor attachment. So this grading system will have to be assessed, and this what grading I had used in the year 2001. You must read on my article, and again my recent article, which will be an experience of many more cases, it is under preparation. Similarly, we had given a grading system for anterior clinodal meningiomas. And anterior clinodal meningiomas are another very great skull-based problems, and depending on the type of encasement of the internal carotid artery, type of extension into the cavernous sinus, type of extension into the paranasal sinus, the size of tumor, various features we had discussed, and we had given a grading system. Like this tumor is not involving the cavernous sinus. It is like a convexity meningioma. But when it involves the cavernous sinus, it is a different tumor. When it goes into the extent of involvement of the internal carotid artery, involvement of the contralateral internal carotid artery, involvement of the basilar artery. So this kind of classification I had given. So that classification and anterior clinodal meningiomas I will discuss with you on another date. But just to show you the pattern of anterior clinodal meningiomas can be different, and how you have to design your surgery will depend on the nature of the tumor. So this is a small anterior clinoidal meningioma, but you can see that it is very heavily calcified. And in this calcified, if it is a large meningioma, the extent of difficulty may be less than this calcified meningioma. You have to be particularly careful because these meningiomas are long-standing meningiomas. The symptoms are very subtle. The tumor is more benign. The extent of surgery is, the difficulty involved in the surgery are more intense, and the outcome of a successful surgery is better. So you have to know the tumor beforehand. So this anterior clinoidal meningioma is not towards the cavernous sinus, but it is on the anterior clinoid process, and the relationship with the internal carotid artery is more intense. If you see this, there is a small amount of tumor which has been left behind on the internal carotid artery. You just cannot, for the sake of complete resection, take any risk. I will say not, of course, if you damage a vessel, that's the end of the story. I will say even not taking a risk with the perforator is important. And as I have mentioned, your character, aggressiveness is very important. You cannot say I'm a conservative surgeon and I am a biopsy surgeon in meningioma. You have to be complete and you have to be radical. So this is an anterior clinoid meningioma which is going in the cavernous sinus. So this meningioma is a different meningioma. Now here, this meningioma, if you see such a meningioma, you must know that the behavior of this meningioma is more aggressive than the tumor which is not involving the cavernous sinus. It is like a convexity meningioma which is not involving the superior parietal sinus. When it is going near the superior parietal sinus, and when it is involving the superior parietal sinus. These are the grades of difficulty of cavernous meningiomas are like superior parietal sinus or paraparietal meningiomas. Not only is the extent of surgical resection difficult, but the behavior of the tumor and the extent of recurrence also is difficult. So when the convexity meningiomas goes in the paranasal sinuses, it becomes more aggressive. You see, when it goes in the paranasal sinuses, it is a different meningioma behaviorally. Size of the tumor matters. Size of the tumor has great implication in our surgery, but some of these tumors coming from branches from the internal carotid artery can be resected, and has been, this one was resected in very quick time, knowing how first get to the base, then work within the tumor. You have to save the arachnoid around the convexity of the tumor. So size matters. Size is another huge thing. This tumor was operated 13 times, this meningioma, then when I removed it. But 13 times does not mean that I have done a great job. This tumor will recur, and this tumor will recur fast and furious. So the size is also a matter, but apart from size, there are various other issues. As I showed you the other day, cavernous sinus surgery is a different kind of surgery. And I had told the panelists last time to read this article of mine. I know many of you may not have read this, but you can quickly note down this reference of this article, and I want you to read this article, which is a very beautiful article. So just to read few lines from this article: meningiomas constitute an important component of neurosurgical life. Technological advances combined with refinement of surgery over the century have ushered a new era in which the meningioma involving the cavernous sinus can be treated. So there are various kinds of beautiful small article. I want you to read it. Sorry. So meningioma, which is going outside the skull, outside the dura, outside the skull, are behaviorally more aggressive. The tumors which destroy the skull are more aggressive. Tumors, meningiomas will come in the paranasal sinuses, are more aggressive kind of tumors and behaviorally aggressive. So then I will like to show you some, of course, petroclival meningiomas. I will show you in another presentation, but I want to show you some characters of these tumors. So this is a tumor with high vascularity. This is tumor with furious vascularity. So when you are doing meningioma surgery, you have to know the vascularity and how to handle blood, how to handle bleeding. Excessive and continuous coagulation may not be the best answer to handle these meningiomas. Where to exactly attack, which part of the tumor to come and attack in this meningioma, and for that matter in this meningioma, how to get to the base of the attachment, coagulate, not much coagulation within the confines of the tumor. So bleeding handling is the part of our life. As we grow in our subject, as we grow more senior and more senior, we can handle the bleeding with more experience and confidence. But this confidence has to be learned and achieved in our lifetime, and we do as we grow further in our business of neurosurgery. This is another end plaque meningioma. End plaque meningiomas are different. This meningioma extending like a trigeminal schwannoma is a different. This is postoperative, but the difficulties and extent of difficulties are different. Tumors going in the orbit. This sphenoid meningiomas, sphenoid wing meningiomas, which go in the orbit, are inherently or behaviorally like malignant tumors. So when you resect these tumors, I will say that this you treat like a malignancy, and adjuvant radiation treatment or other kind of adjuvant treatment is mandatory for such tumors which go into the orbit, involve both sides of lesser wing of sphenoid ridge. In my experience, normally I don't like radiation for meningiomas, but this is one meningioma where I will say radiation is a part of the game. This is another huge petroclival meningioma. So depending on where the tumor arises, the relationship with the base of the skull, the surgical difficulties will be encountered, how deep is the tumor, and how you will get to the base of the tumor. So anterior clinoidal meningiomas, I had divided into grading system on the basis of visual loss. Vision was one parameter of mine. Worse the vision, more difficult the tumor resection. Better the vision or good the vision, the surgery was easier. Larger the tumor, more difficult the tumor resection. Smaller the tumor, easier the resection. But then there are other parameters like calcification within the tumor, more difficult is the tumor resection. Displacement of the internal carotid artery, encasement of the internal carotid artery and narrowing of the artery, involvement of the opposite ICA and basilar. So these were the various parameters where we graded this anterior clinoidal meningiomas. Not only the meningiomas grading by radiology, but pathology itself also is different. There is no two tumor, no two meningiomas which are similar. WHO divides meningioma into 3 grades, and I will say that it is impossible to grade meningioma on the variation in the histopathology, because all tumors are different. WHO classification is based on histopathological variants, on the kind of brain invasion, on the proliferation index, and on the mitotic activity and the degree of necrosis. This is the World WHO grading system. So all meningiomas, you see there are several varieties of meningiomas, meningothelial, transitional, fibroblastic, all have different histological variation, mitotic variation, DNA activity, and so many other features. So what I'm trying to say is, you cannot say that I will have one strategy for meningioma. Your strategy has to be different for each situation. And as the situation demands, you have to do variation in your surgical strategy. So these are invasive this is an invasive meningioma where it is invading into the brain parenchyma, and this tumor is atypical or aggressive meningioma, and you have to resort to adjuvant treatment in this situation. So there are various types of meningiomas that you know, that you have heard of, and the MIB index is different. So in meningiomas, there is a stage of discrete silence. the tumor grows and grows and grows when the patient does not know the tumor is growing to the size when it grows huge. So there is a discrete silence, and the tumor grows in size. So tumor which grows on both sides of the falx is a different tumor. Tumor goes on both sides of the falx. It grows huge in size before getting diagnosed. Tumor having calcification. Tumor getting feeders from the convexity. Feeders getting feeder from the convexity with an anostosis, with a bigger anostosis. And you see involvement of the bone of the calvarium by the tumor. Involvement of the bone by the meningioma. These are different meningiomas. So even the convexity meningiomas are different. And there is a meningeal artery supplying the calvarium. Whether to remove this part or whether you can avoid removing this part of the tumor. So you cannot, even for convexity meningiomas, your extent of resection, you have to remove this bone if you have to resect this tumor radically. Involvement calvarium is different in convexity meningiomas. You see how the calvarium is involved by this tumor and how the tumor is extending along the convexity. Here the tumor, intracranial part of the tumor is smaller, but the calvarial part is more, and extracalvarial is more. So this is mainly a different type of a convexity meningioma. Similarly, there is the lesser wing of sphenoid bone can be involved in different pattern. And there is a branch of the internal carotid artery, which meningeal branch, which is supplying the bony part of the tumor. So you will get bleeding when you operate on this. You will get bleeding from the bone, bleeding from the base of the tumor. So this tumor involves removal of this tumor rather than more difficult will be this tumor resection. Bone involvement can be different in different tumors. This tumor with a tail, you see there is a tail and you have to, how much tail you can resect, this will depend on how much aggressive you are. But whether the removal of the tail is mandatory or not is an issue. Sometimes the tail can extend all over the place. So holding the tail is very important, but I am not sure how much you can remove in various situations. Here the tail is bigger than the tumor. And here there is only tail and the tumor is not so much. So the tail, see here tail. So this is a game of tail. You see this kind of extensive meningioma. So the extent of meningioma can be different. Extent of involvement of suprachiasmatic sinus is different. Now this is a very beautiful meningioma which I am showing you. You see this is the meningioma and how the brain is handling that meningioma. Some of the brain has herniated down into the paranasal sinus. This is a huge meningioma, and you will not believe that this patient comes with only a marginal headache for last 2 or 3 months, because the brain has been accommodating this tumor for a long time, and even the brain has herniated down into the skull outside the brain to accommodate this tumor. So this is how the nature plays its game in accommodating this tumor. As I showed you the other day, you have to be exactly knowing how to get hold of this lion. If you know how to handle it, this mountain, in the foothills of this mountain, I had removed this huge meningioma, which was the largest meningioma which was ever removed in the history of neurosurgery at that time. Subsequently, I realized it was 1.46 kilogram. At that time, I had removed, this was the heaviest, but I know that subsequently heavier tumor has been removed. So this was and this patient, if you realize, this patient had come with the symptom of neck pain from a village. He had come from a village and he had come with the symptom of neck pain. And the doctors also were very intelligent and they did MRI of the neck, and this was not even imaged. And he was advised surgery for cervical spondylosis. So when he came to me, he was not able to even bend down because that was a very difficult maneuver for him, and this pain. So many of these tumors come with very weird kind of symptoms, accommodation, this going extension. So this was one meningioma. And this after the surgery, certainly looked more handsome. Some of this tumor was left behind and this was subjected to radiation. This patient never had neck pain and unfortunately he never returned back to me. But this fellow was found in a bus by one of my residents, and then he had a hat on, and my resident wanted to touch his head, but he didn't allow. But there was some recurrence some years later, but he has never returned. So meningiomas can be different. This is another beautiful meningioma that you can see. There are two histological variants of meningioma in the same tumor. This was different histology. This was different histology. Both these meningiomas were of different nature, histological pattern. And I had removed this tumor and there was a big recurrence of this meningioma after some years. So same two tumors in one tumor. This is another meningioma having two tumors in one meningioma, two histological variations of the tumor in one bulk of the tumor. So in short, what I'm saying, in once a meningioma, always a meningioma. You remove the tumor, the whole tumor, and nothing but the tumor without removing the tumor diathesis or the ability to form the tumor. You must realize your infinite potential to harm when you are removing the tumor. Tumors are the spatial problem demanding spatial solution only. The surgeon's role is to respect the space-seeking faculty of the tumor and hence attempting to reduce the bulk of the tumor and increase the space available for the tumor to be. I am going to show you petroclival meningioma in my next series, in my next presentation, but just to show you some tumors. You see, these tumors can be difficult, these can be dangerous, and in 1992 or 93, I removed this tumor. You can give new life. This tumor did not recur at least for 10 years, after which I don't have a follow-up, but you can give a new life. You can give a productive life to these tumors. Whether to give radiation to these tumors is a questionable issue. I don't like to give radiation, but if I like to, even if the tumor recurs, I will like to reoperate rather than give radiation. But if it is beyond my knife, I will like to give radiation. This is another tumor I had done several years ago. I had left some tumor behind in this youngish lady at that time. I had done when she was about 20 years old. She came back to me with a huge recurrence after 10 or 12 years. But in the meantime, she had produced two very beautiful boys. I reoperated this, but she did not survive the reoperation. So I have to only say, even if you have a difficult tumor, you can give new life to the person. But whether the tumor will recur, whether the tumor will not recur is beyond your control. You have to be aggressive in your character. You see this tumor encasing the basilar artery. I had done several years ago this tumor, and I had left a lot of tumor behind. I had a good follow-up for 3 or 4 years after that. After that, I have no follow-up. I'm not sure this patient has survived for a longer period of time, but this patient at least had 4 or 5 years of wonderful life. If you give good respect to all the blood vessels outside the dome of the tumor, that is the basis of surgery. Complete radical resection and complete resection is the aim of the operation. But sacrifice of one vessel can be completely disastrous. This is another tumor. There is a complete basilar artery encasement. You imagine the encasement of perforators and other blood vessels. I had left some tumor behind. I had a recurrence in this patient after 4 or 5 years, which I reoperated, and again I did a partial resection. After that, I had subjected this person for radiation treatment, and I am sure this patient is doing well, and she has not come back to me. This is another beautiful tumor, and somebody had operated this tumor, removed large part of the temporal brain, but did not remove the tumor. So we removed this tumor in this young girl. You see there is some hemiparesis after the operation, but this girl also has survived for 7 or 8 or 9 years. She was following up with me on a regular basis. Then for last 7 or 8 or 10 years, she has not followed up with me, but we could give a good at least 10 years of life to this young girl. So in my book, I had shown you the other day, we have discussed how my exposures were earlier in my development of meningioma surgery. My exposures were very, very massive and huge. Mobilization of facial nerve, mobilization of internal carotid artery, mobilization and resection of bone was a very important part of my surgical development. I showed you the other day, cutting of the GSPN and mobilization of tympanic and the labyrinthine segment was first described by us in this article. But subsequently, my exposures have become small. Conventional petroclival meningioma, you know, Sami had described retrosigmoid approach for these tumors. Then we described for the first time in the literature the most outstanding approach to petroclival meningioma, supracerebellar approach to petroclival meningiomas. I think this was one of my very beautiful, although now many of the tumors going in the petroclival areas are resected by this approach, supracerebellar approach to petroclival meningiomas. Similarly, foramen magnum tumors, we used to do all kind of condylar resection and all kind of vertebral artery mobilization and things like that. But then we describe foramen magnum meningiomas by a conventional midline suboccipital approach. What beautiful approach. And now for all foramen magnum meningiomas, we do just a conventional suboccipital approach. In my subsequent presentation, I am going to talk on foramen magnum meningiomas. I'm sure you will attend that seminar. So all meningiomas can be classified into good or bad meningiomas only in retrospect. After 2 years or 5 years of surgery, you will say, oh, that meningioma was a good meningioma. Oh, that meningioma, if it recurs, it was a bad meningioma. You cannot ever say this is a good meningioma or bad meningioma early in your curing is a non-issue in meningioma. You don't ever use the word that I have cured the person of meningioma. Curing is a non-issue. You remove the meningioma, you remove it radically, but you have to remove it safely. You never say that you have taken the risk because you wanted to have a long-term better outcome. Long-term better outcome, of course, is determined by your extent of resection, but you can never have a control on the growth of future of a meningioma. Another beautiful statement I had made the other day for you, and I am completely, this is what my philosophy is, that recurrence of a meningioma is independent on the extent of tumor resection. You cannot say I have removed the tumor and the tumor will never recur. It's completely not a correct sentence. The cause, course, and cure of any meningioma is not only not known, but it is unlikely to be known. You can only debulk. Debulk means not biopsy, not small resection. This word is not debulking surgery. Debulking, if your attitude is debulking, you will never remove any tumor. When I use the word debulking, means it is not just half removal or 50% removal or 60% removal. Debulking means you cannot remove the tumor or total tumor removal. Complete cure is only a dream. Even if it were totally removed, the next normal meninx can throw a meningiomatous tantrum and the tumor might recur. My message is not that you should not be aggressive. My message is that you have to be restrained in your approach. You have to be controlled in your approach. You cannot take a risk with the blood vessels, and you have to preserve the blood vessels, and you have to preserve the cranial nerves. The other question is, can we do research on meningiomas? These are quite philosophical terminology. I will say that each meningioma is unique and not amenable to any genetic analysis, prevention, chemotherapy, or radiation. You cannot ever have a genetic analysis of the person and you can say, I will prevent a person from meningioma or chemotherapy or radiation. It is better lived with ablated when diseasing and re-ablated when it recurs, when it diseases again. This is particularly true for cavernous sinus meningiomas. It is not the treatment but cellular behavior of the tumor of a meningioma that decides the long-term outcome. As I showed you the other day, every neurosurgeon should have a plaque in front of his clinic stating that there are some patients whom we cannot help. There are none whom we cannot harm. We must remember that meningioma is our life. We should learn to remove meningioma. We should learn to be aggressive with meningioma. We develop our science of neurosurgery with meningioma. We should learn to respect these beautiful tumors. Surgical philosophy for all tumors, benign or malignant, is to remove the tumor radically and then fold hands and wait for it to recur. See this beautiful sentence, you must read it properly or it will be on the internet. Again, you can copy it, beautiful sentence. Palliation, you can never use the word cure for a meningioma. Between the idea of benignancy and the reality, between the seen and the seer, falls a shadow of ambiguity. Conclusions are: resect the meningioma radically. Patient should improve in symptoms. If symptomatic, then reoperate. Role of radiation therapy has to be properly monitored and aggressively done. To be conscious that you are ignorant is a great step towards knowledge. Thank you very much, my dear friends.
Okay, thank you very much. Thank you very much, Dr. Goel. Another
I
classic.
hope you enjoyed it. This was a different kind. This is a different kind of presentation. I normally don't make this kind of usually in our business of neurosurgery, we show our aggression, we show our results, we show how aggressively we have removed the tumor. And I will do that kind of show thing in my next presentation on petroclival meningioma, on foramen magnum meningioma, and my surgical strategy on those tumors. I will like to show you, but in different presentation.
Okay, we look forward to that. Let's open it up. There's lots of questions, I believe. Okay, the floor is open for just jump in and ask the question. Go ahead.
Yes, thank you for your great lecture, as usual. As you said that the good or bad meningioma, we can know this post-operative. But actually, during practice, I need your comments that when I read the MRI and the T2 for the meningioma and see it very bright, I feel that this tumor is soft, and this will make me happy during this dissection, during the operation. And you said something different. The second point, that during operation, when I have found arachnoid membrane in the tumor, between it and the vessels, this is make me safe in the tumor dissection. So what's your comment, please?
So this is, as I was mentioning, that more the experience we develop. Of course, you are a senior neurosurgeon. You have seen many meningiomas in your lifetime. You will know during operation as to how the tumor is behaving with the arachnoid. You will know how much it is stuck to the internal carotid artery. You will know how much you can dissect from the perforators. You can know how far to go. That learning process has to continue. We keep on learning this as we grow further. How much, if you see preoperative MRI, as you mentioned, how much it is, there is T2 weighted, how much FLAIR imaging, T2 weighted imaging, how much is the response of the brain to the tumor. And then we have to learn to identify, you know, sometimes for pituitary meningioma, it goes in the brain, in the brainstem. How much is the brainstem involved? So many, on some of these pituitary meningiomas, the brainstem can have quite a bit of a response. You know, we know all these things. Depending on that and how much you see during operation, you have to decide how aggressive you can. So you can never say, I have learned meningioma. You can never say, I am now master of meningiomas. You can never say, I am the king of meningiomas. I have learned this. Small mistake during operation can destroy the operation and can destroy your happiness for next 1 week or 2 weeks and can destroy the happiness of the patient for his lifetime. So you have to learn meningiomas. That is what my message is. That is what my message is.
Thank you.
Hello, John. Hello, John.
Yes, yes, Victor, yes.
Yes, just 2 words for this lecture. Excellent, impressive lecture. Thank you so much.
Thank you, Victor. So nice of you. We all know your beautiful work. I know you personally for such a long time. And Mexico, I have been, you will be happy to know that I'm an honorary neurologist of Mexico, Mexican neurosurgery. So I have good relationship with Mexico for a long time.
Thank you.
Thank you very much. Thank you very much, Victor.
Hello.
Yes, any other question? Yeah.
Thank you, Prof, for this lecture. I want to ask you about tuberculum cell meningioma. Do you prefer to open the roof of the optic nerve before starting debulking the tumor?
Yes, this is also a very beautiful question, very fantastic question. Now, many people who are doing tuberculum cell meningiomas like to come and do optic canal opening early in the operation. My surgical strategy is that I do not open the optic canal early in the operation. I first remove the tumor and see when I get space after removal of the tumor. Then I open the optic canal and see how the tumor is going. So to answer your question, I do not, many surgeons I know, first open the optic canal and then go and remove the tumor. I do not do like that. I first remove the tumor and then after the field has relaxed, I like to see how the tumor is extending. And if it is extending in the optic canal under my vision, then I remove the optic canal part. And as you know, unless you remove the part of the tumor extending into the optic canal, you may not be able to completely cure the vision, improve the vision. Sometimes you have not removed the part in the optic canal, the person may not improve in the vision. So you have to remove the part in the optic canal for sure.
Thank you.
Prof, hi, it's Ali Alavi from Australia. Thanks for a nice presentation. Just a quick question. What is your experience with the pre-op endovascular embolization to minimize the
Yes, this is another
bleeding
question.
for meningiomas?
Yeah. So this question is whether endovascular embolization to reduce the intraoperative bleeding in meningioma is necessary or not, or whether I do an embolization of the meningioma before operation in case the tumor is vascular meningioma. To answer that question is, I do not do embolization for meningiomas. Now you will ask me which tumors you like to embolize. I like to embolize very rarely any intracranial tumor. The only tumor I will like to probably embolize is glomus jugulare tumors. I have had very bad experience with embolizing nasopharyngeal angiofibromas. I have at least in my series 3 patients or more where we attempted embolization and the person became blind by embolization. So I have had very nasty experience with embolization of nasopharyngeal angiofibromas, which is one tumor I used to embolize. I used to embolize glomus tumors on a regular basis. I'm not very sure whether embolization is good for glomus jugulare tumors. But for meningiomas, certainly, I never will recommend and never do preoperative embolization to answer your question.
Okay, thank you.
Thank you.
Thank you very much, Professor Goel. My name is Dr. Guga from Enugu, Nigeria.
Yes.
Yes, I really enjoyed your lecture. Thank you very much, sir.
Thank you.
Yeah, I have just one question. Recently, we had a patient with middle third parasital meningioma. Sorry, I'm a resident. I didn't mention that. Parasital meningioma, middle third, that was resected with a little cuff left on the parasital sinus. But the histology said transitional meningioma, which is grade 2 WHO. That within 4 months of the surgery, the patient had a recurrence.
Yes.
It was really huge, almost bigger than initial tumor. So my question is, what has been your experience with regards to the latency between excision and recurrence? What have been like your shortest intervals between excision and recurrence?
As I mentioned to you, parasagittal meningiomas all parasagittal meningiomas are different. Histologically different, radiologically different. Some meningiomas may go into the superior sagittal sinus. Some may involve the superior sagittal sinus quite aggressively. Now, my experience is when the tumor involves the superior sagittal sinus, the chances of recurrence of these tumors is much higher than the tumor which does not involve the superior sagittal sinus. Now the question will be whether to remove the part of the tumor that goes in the superior sagittal sinus. Sometimes it is relatively easy when the tumor is soft. You can go along the tumor base and resect the part of the tumor in the superior sagittal sinus. But you can also anticipate when you suddenly remove the tumor from the superior sagittal sinus, there can be huge bleeding and you have to be prepared to control that bleeding. And every kind of bleeding has a different method to control in that situation. So the question is the extent of resection matters, but the behavior, the histology, in this case of yours was a transitional meningioma, but even transitional meningiomas can recur. So your job is, the job of a neurosurgeon is at this point to resect the tumor radically, to resect the tumor aggressively, but you have no control on the recurrence rate. If it has recurred, you have to again resect this tumor if you think you can safely do it. If you cannot safely do it, you have to subject this patient to non-surgical kind of treatment, and then the radiation will come into picture. Radiation will come in the picture when your knife is not able to reach the surgical field.
Thank you, Prof.
Thank you. Nice to see you, young man.
Thank you, sir. Excellent lecture.
Thank you.
Good evening,
Hello.
Mr. Professor.
Go ahead.
One question, John.
Sure. Wait, could you identify yourself, please?
Hello.
Yeah.
Yes.
You can hear you. Go ahead.
I'm Rustam Bek from Uzbekistan. One question: how is to avoid, your opinion, best way? Maybe in use during the operation, all of the technical about ultrasound, Doppler, or navigation, because most of the meningiomas involve the cavernous sinus or ACA. It's change the anatomical point. What is the best way avoid the damage of the vessels?
See, you have to, to avoid the vessels, avoid injury to the vessel is the key, is the basis of our operation. We are going to operate on the meningioma. We have to avoid the blood vessel injury, and that is the basis. Now, whether we can use other adjuncts like ultrasound to identify whether the artery is encased or not during the operation, whether navigation can be used or not to find out how far we are in the operation and how far the vessel is involving after we have resected the tumor, where are we in relationship to the internal carotid artery, for that matter, in cavernous sinus. I think navigation can be a good option. Ultrasound may be a good option, but to tell you, I do not use these options in my surgical. We have all these things available for us. I use navigation. When I will talk to you about gliomas, I want to talk to you about how navigation can be used. When I will talk about gliomas, I will tell you how I use ultrasound. When I will talk about other tumors, I will let you know where I use navigation and ultrasound. But for meningiomas, the whole science of meningioma revolves around our strategy of saving the blood vessels. And that is the key. I do not use ultrasound and navigation when I am operating a meningioma.
Okay. Unfortunately, just wait a second. He'll be back. He dropped off. So just hang in there. Let's see, who has a question? Apurva Prasad, correct? You have a question? Oh,
Yeah, John, I'm on the phone now.
okay, go ahead.
Just a minute. Sorry. Yes, John, I'm with you.
Yeah, okay, let me get rid of the echo there, hold on. You have some, you're in two devices there, audio, so let me try to get off.
Yes, sorry.
Okay.
Now you can hear better?
Yeah. Can't hear it all now. I'm sorry, I gotta mute you there. You might get the echo back. I can't hear you. Okay, we can hear you now. Okay.
Okay. So that was my answer to that question. Any other question?
Hi.
Go ahead.
Hi, I'm Rafiq. I'm a young neurosurgeon from Algeria.
Welcome.
Yes.
Thank you, Professor, for such a fantastic presentation. So I want to ask you, please, about big meningioma of the skull base. You, in your presentation, you said that you have to handle bleeding. So how to get access to the feeding artery in the basal part of the tumor without coagulating around and in the tumor? That's my question.
So that is the, you know what? if you really ask me, my whole life, I've spent my whole life in controlling bleeding. Vascular tumors, cavernous sinus tumors, petroclival tumors, arteriovenous malformation. I'm not sure you were present in my presentation. I showed you some AVMs the other day. You were there?
No,
You were there in my AV?
No, I didn't assist that. Sorry.
So AVM, so bleeding is my life. And how to control bleeding is you have to learn, develop the art of controlling the bleeding. You have to learn the meningioma. You have to know the meningiomas. You have to know where is the feeding from the meningiomas. You have to go to the base of meningioma, but to go to the base of meningioma, you have to have space to you remove some tumor. Some tumors, you have to go right to the base of the tumor. Coagulate in the base of the tumor. Coagulation within the tumor is not such a good idea. Coagulation outside the tumor, dome of the tumor, is maybe a technical, very big mistake in the technique of the tumor resection. It is important to remove the tumor, first get space, and then coagulate the base. Do not waste too much time in intratumoral resection in most cases. I'm not saying in all cases. And preserve the dome of the tumor. As I repeatedly mentioned in my presentation, it is very important to preserve small vessels within the tumor, which are normal vessels. If you take one normal vessel, you can create big disaster in the operation. So you have to learn, my dear young friend, you have to grow, and I want to see you sometime, and I want you to come and see me in my own territories sometime in your lifetime. I hope you can come.
Very good. Okay, let me unmute your effect. I'm sorry, I muted you.
I had another question, please.
Go ahead.
Yeah, Professor, please, what do you think about endoscopic approach for the midline tumors of the anterior and middle skull base?
This is
Meningioma, of course.
This is a very good question for a young boy like you, but I have to tell you that tuberculum celli meningiomas and olfactory groove meningiomas should never be resected by endoscope. To remove tuberculum celli meningioma by endoscope, you know how to use endoscope, and you go ahead and remove by tuberculum celli meningiomas. And some tumors, easy tumors, you can remove here and there. But to answer your question and to take answer from me, I will say tuberculum celli meningioma, planum sphenoidal meningiomas, diaphragm celli meningiomas, olfactory groove meningiomas are to be done by a transcranial route is the best route to operate these tumors. Endoscope should not be used. That is my answer.
Okay.
Thank you, sir.
Thank you. The next question or comment? There is one, let me read this one comment, Doctor. Do you think that 3D devascularizing, the dressing, debulking can be done regardless of the size of the tumor? I'm not sure.
Yes.
Okay. Okay.
Of course it can be done.
Okay.
And it should be, you have to ultimately demolish the tumor. You have to learn the art of breaking the tumor. The whole neurosurgery depends on how you handle the tumor. What is your art of demolition? How you break the tumor, how you break the bones of the tumor, how you demolish it. That is our learning process of our life. The whole life with tumor surgery depends on how we learn the art of breaking the tumor, breaking the tumor, breaking the tumor, whether you use CUSA to break the tumor, whether you break with your suction, whether you break with your tumor handling instruments. It depends on how you remove, but ultimately you have to demolish, and that art you will learn only by your experience. As you grow senior in your business of neurosurgery, you learn that art, and that each surgeon will have a different art of removing the tumor, but ultimately that tumor has to be demolished, and demolished safely, not for sake of giving a beautiful post-operative image, but for the patient, and the patient should be enjoying the operation more than the surgeon to enjoy the operation. You are doing it for the patient. Thank you very much, my dear friends.
Okay.
Hello, good evening, sir. This is Apur
Go
from
ahead.
Mumbai.
Go ahead.
Thank you for the stimulating lecture, sir. I have two questions, sir. I'll put the first one forward. So for tumors which have a calvarial involvement, more specifically an extracalvarial involvement, so when do you decide to put the bone flap back? And if not, how do you plan to reconstruct the bony defect?
Very fantastic question, my dear. You see, this also will depend on the individual case. When the bone is grossly involved by the tumor, of course, you will have to remove that bone. And then you immediately replace some artificial material and reconstruct the calvarium immediately. There's no point in waiting for after 3 months or 6 months. You immediately make that defect, you can reconstruct. That will depend also on the extent of calvarial involvement. But if it is a smallish calvarial involvement, you drill off that calvarial involvement. I don't like to sacrifice the bone. I like to replace the bone then and there. It is very rarely that I will sacrifice the bone. In my whole neurosurgery, I never like to sacrifice the bone. I never like to throw away the bone flap. You know it.
Yes, sir.
Or any kind of, this word decompression is not in my history of neurosurgery. This word decompressive craniectomies and all has never, maybe I will give another lecture on decompression for neurosurgery, but resection, but sacrifice of the bone flap is very rarely done in my story. Okay?
Thank you, sir. So one more question. Sir, as you said that for nasopharyngeal angiomas and for maybe glomus tumors, you like to have, there is a scope for embolization in these tumors. Like the case you showed, sir, of the petroclival meningioma, which had an angiographically demonstrable vascularity under tumor blush, would the embolization make your surgery difficult or easier when we have a angiographically demonstrable blush?
Whether there is a blush or not blush. For meningiomas, I do not like to do preoperative embolization.
Yes.
That is my way of handling vascularity. Even if it is vascular and highly vascular, if it is clearly a meningioma, I do not like to do embolization. However, there are some meningiomas like hemangiopericystoma kind of a story.
Yes, sir.
I have not done embolization for a long time, but maybe in some of those very, very aggressive vascular tumors, maybe I do sometime, maybe I will like to do. But in general, this is in general, I do not like to embolize any meningioma for that matter.
Okay, thank you, sir.
Okay, more questions?
Yes, Professor Goel, I remember some points I want to ask about it, if you don't mind.
Sure.
When you take your decision to open the Sylvian fissure for the Supra cellar meningioma, is it for all cases, or you take your decision during the operation? And what is your tricks to release CSF in the huge tumors, please?
Yeah, that is another very beautiful question. There is no question. There is, you have to open the Sylvian fissure. As I mentioned, I do basal, lateral, subfrontal approach for tuberculum celli meningiomas, for all meningiomas. Now, as I mentioned to you, supracellular meningiomas is a very favorite operation of mine. My experience is nearing 300 cases, which is the largest experience in the world on these tumors. I go subfrontal, open the Sylvian fissure very early in the operation. Very early in the operation. Because you have to have a relaxed brain. Because if you see, even by pterional exposure, you can have Sylvian fissure early in the, but for the subfrontal, You have to learn how to open the sylvian fissure very early in the operation. I think if you do not open the sylvian fissure, your brain will not relax and your exposure will not be good. So you have to, in all cases, you see, even if not lateral sylvian fissure, medial sylvian fissure, near the optic nerve and internal carotid artery bifurcation, in that area, if you release the CSF, the brain will relax. You need not open the lateral part of the sylvian fissure in tuberculum celli meningiomas.
Thank you very much.
Okay, more questions, comments? Let me ask one, Professor. Can large calcified aneurysms mimic like meningiomas, and is the strategy of removal different?
Of course, calcification can be in aneurysm on a rare situation. Aneurysms can be calcified. The blood within the aneurysm can be completely calcified and it may look like a meningioma. And when it happens, and if you have not diagnosed it properly, you can have a disaster during the operation. You are removing the calcified part of the, you go inside and you open the blood vessel, then you will immediately realize that this is not a meningioma. And if it is not a meningioma, then your surgery is different. So you open by mistake. Mistakes will happen in our life. In our neurosurgery life, mistakes will happen all the time. And this kind of a gross mistake that you have mistaken an aneurysm for a meningioma, it can happen. I'm not saying it cannot happen. If it happens, then when you expose, you will see an aneurysm, and then you have to then prepare a different surgical strategy. If the symptomatic presentation of a calcified aneurysm will be a different presentation. They may present, even calcified aneurysm can present with a bleed. Even calcified aneurysm may have a flow within the aneurysm. So then you will have to be very, very clear as to what your aims are, whether you will like to do some kind of a bypass, means your surgery is different. Then your complete scope of surgery will be different.
Okay. Let's see. More questions, comments from the panelists? There's a couple in the chat box I'm trying to find here.
John?
Yes.
I got many messages saying that I'm showing papers and all. They want to have papers from me and summary of my work. So tomorrow I have decided, you see, one is my work on cranial neurosurgery, skull-based neurosurgery. And one is my work on spinal neurosurgery, like craniovertebral junction, which I presented, and spine, cervical spine, OPLL. So tomorrow, I am going to give a summary of my cranial, my papers and my articles on cranial neurosurgery. Okay. So I will just summarize my own contributions and my own articles in cranial neurosurgery tomorrow. And then in subsequent articles, presentation, I will give my other presentations. So tomorrow you be prepared for cranial summary of my cranial work. Okay. And of course, I will present on petroclival meningioma in one presentation. Then my one presentation will be on epidermoids and endodermal tumors. Then one will be on cavernous hemangioma. And then I will show on supracellular meningioma, some operative videos. Then the whole month, there will be something or the other.
Okay, we'll communicate later about that, because I mistakenly missed your message about speaking on this topic today. I thought it was philosophy of neurosurgery. I missed that.
Also, I want to talk to you on philosophy of for a neurosurgeon. That will be my last presentation for you, philosophy.
Okay.
That will be
coming later. Is it also petroclival meningiomas tomorrow, or strictly the references? Okay, we'll talk later. We'll talk later about that. That's okay.
Yeah, yeah.
Okay, more comments, questions? I'm sure there is a couple in the chat box I'm trying to find. Let's see. Okay, did you audit those cases who became blind after embolization? Was it due to faulty embolization or something else?
This is a, you see, I will give you an example. Now a young boy comes to me with a large nasopharyngeal angiofibroma. And then he disappears from me. And then he goes to some other surgical facility and they do embolization. And they do embolization, and following that embolization, the whole nasopharyngeal tumor angiofibroma is still there, and the boy becomes completely blind after operation. What will be your reaction when you see such a person? It is a devastation. You have not removed the tumor, and then I remove the tumor, and the boy never improves in vision. I have got 3 patients like this. Do you think I will still resolve to embolization for nasopharyngeal angiofibromas? I will say no. Now you will ask me whether embolization was faulty or whether they have not done a good embolization. You see, I am not expert in embolization. I will not say embolization was wrong and then don't know how to do embolization, but I must tell you, we have one of the most elaborate embolization people in the whole world. And I have been working with people who are doing neuroradiology, one of the best centers for teaching neuroradiology in the whole world. And it will be very bad on my part if I say they do not know how to do embolization. But I can only tell you that embolization for nasopharyngeal angiofibromas can be a dangerous issue, and I will not do it. If you like, you please go ahead and do it. So that is my answer to your question.
Okay. Next question.
In that situation, you have to learn to handle bleeding. Nasopharyngeal angiofibromas are vascular tumors. Glomus tumors are vascular tumors. If you say, I don't want blood, I want a clean field and all, then nasopharyngeal angiofibromas are not tumors which we should do in that situation. It is a vascular tumor. You have to know how to handle angiofibromas. And you have to know how to demolish angiofibromas. You have to know how to do glomus tumor. If you are saying, I will like to have a bloodless field in glomus tumor, no amount of embolization will completely, I have not said I will not use embolization for glomus tumor. This is one tumor I still embolize in some cases, not in all cases. So you have to learn how to control the bleeding in that situation.
Okay. Perhaps you may have answered this already, Doc, but what is your take on preoperative embolization? I think you already went through that.
Yes.
Okay. Let's see. Yeah, a couple of questions on embolization. Okay, here's the general one. What is the main cause of recurrence, and how do we lessen recurrence?
You know what? The thing is, I don't know whether I put my slide, but our job is to remove the tumor safely, to remove the tumor aggressively, and then fold our hands and pray to God, and let the patient also pray to God, and wait for recurrence to happen, and wait for recurrence not to happen. I think those things only some supernatural power can help in avoiding the recurrence. Of course, the mitotic activity of the tumor, the stage of the tumor, the nature of the tumor. If it is atypical tumor, if it is aggressive tumor, then you can maybe resort to some kind of radiation treatment, some kind of adjuvant treatment. And now there are adjuvant treatment is also very heavily improving in the world of neurosurgery. That may be a useful way of treating some kind of and avoiding a recurrence. But for a surgeon, we have to remove it safely, radically, beautifully, properly, majestically, keeping everything under control, beautifully sit down like a tiger in the operative field, have a beautiful microscope, control the microscope beautifully, and then be a tiger in the operation theater.
Okay, here's a question from Tazar. In cases of anterior fossa meningioma, you mentioned frontal lobe herniated into the PNS due to large meningioma. How do you reconstruct the anterior cranial fossa?
Yeah, that is another very important question. When you remove the tumor, the whole anterior cranial fossa will be open, and then you have to reconstruct. So I will give you my philosophy of reconstruction. And I have to tell you that if you read my various articles, there are several articles of mine focused on reconstruction. Maybe some presentation I will give you my techniques of reconstruction. I have described at least 10 ways of vascularized pedicle reconstruction of the skull base, my technique of using pericranial flap for reconstruction, osteomyoplastic flap for reconstruction, extended facial flaps. There are at least 10 flaps of mine, and I will show you in one of my subsequent lectures. You keep a watch. As long as the corona is keeping us home, my lectures will come daily. And in one of these lectures, I will give you the techniques of reconstruction of skull base, okay?
Okay, we have one here that's a good one. Please give me some tips on how to devascularize these supracellular meningiomas early in the operation.
What's that?
Yeah, please give me some tips on how to devascularize supracellular meningiomas early in the operation. Does that make sense?
Yes. See, supracellular meningiomas, first thing is you expose the area, open the sylvian fissure, make the brain relaxed. That is the first step of the operation. Second step of the operation will be to identify the optic nerve, which can sometimes be difficult. Then you identify the tumor in relationship to the optic nerve. Then my strategy is to understand the tumor, whether it is a soft tumor, whether it is a firm tumor, whether it is a vascular tumor. Then start resecting the tumor away from the optic nerve. The only way to devascularize tumor is come to the base of the tumor, coagulate the site of attachment of the tumor, coagulate the site tumor vascular attachment. Simultaneously, you remove the tumor. Simultaneously, you remove the tumor. It may be that you are operating in a bloody field, but the only thing that you should coagulate is the base of attachment of the tumor. And then you simultaneously resect and debulk the tumor, and you get space for yourself. And then you first thing in the whole business is to identify the internal carotid artery and anterior cerebral artery and the branches going towards the tumor and attached to the tumor, and save this anterior cerebral artery. So it is a matter of, inside the tumor, there is no need to coagulate. Outside the dome of the tumor is a dangerous maneuver to coagulate. The base has to be coagulated quite heavily and early in the operation to devascularize it. So that is my answer. I will show you some videos in the later part of my presentation series.
Okay. Okay, doctor, I'd like to thank you for all the time you took today. And we look forward to seeing you tomorrow.
Okay. Okay, John, thank you
for
organizing this for me.
Great.
And thank you all the panelists. Thank you very much.
Great.
Thank you. Thank you, sir.
Thank you, Professor Goel.
Very
Bye
good.
bye.
Before we go, I just want to show you guys something on my part, Atul. I'm kind of marketing here. I'm just showing we have a lecture in Grand Rounds of Neurosurgery in Latin America. It's in Spanish. With this gentleman's going to lecture next Thursday, Roberto Herrera. He's big on intraoperative MRI. He's going to give a lecture here next Thursday. But tomorrow he gives one in Spanish. So thank you very much, and we'll see you tomorrow.
Thank you, John. Thank you. Thank you very much.
Thank you,
Bye-bye.
sir.
Thank you.